Well, thank you, Sherry, for that wonderful introduction, clearly off the top of your head. And also to Sarah for helping to organize this event, inviting me to speak. It's great to see such a big crowd here. Might all ask ourselves what we're doing here on such a beautiful day, but I'm glad to have you all here to share some, I think, important information from a recent impact report that we developed and which I'll slowly get into. And I was just speaking to Brittany a few minutes ago, who didn't even realize I was a gastroenterologist, and mentioning that I have maybe 400 to 600 IBD patients in my practice, and yet I recognize only a handful of faces in this crowd, which speaks to how prevalent IBD is becoming as a disease in our society, and in the Ottawa region. So I wanted to, this talk is not necessarily as much about treating IBD. I've given those talks before. This is more about the burden of IBD in Canada. And I think it's important to reflect on because as you know, all diseases vie for competing resources, it's going to be important for Crohn's and colitis to have their message heard as being an important and growing disease. You know, historically, it hasn't gotten the same kind of press as certain diseases, diabetes, heart disease, cancer. But the toll it takes on people's lives, both in terms of quality of life, but also in terms of important factors that often aren't thought of, such as productivity, career growth, things of that nature, is huge. It's a disease that affects young people, unlike many chronic diseases that get a lot of press and a lot of money in society. So those are sort of the underpinnings of developing an impact report to help policymakers and payers understand the burden of this disease, and particularly in the Canadian context. So the 2018 IBD Impact Report, it's available online. It's a 100-page document, but fortunately we created bullet lists of the take-home messages. So if you read the first page or two of every chapter, you'd pretty much have a good idea of what IBD is in Canada. And I'm happy to send Sherry the link, but it's right at the bottom there. And there's also a accompanying manuscript that's published in the Journal Canadian Association of Gastroenterology, mostly intended for physicians, but that's also a good read. So we developed a steering committee to lead this project somewhere in 2017. The first impact report was released in 2012, and this was meant to be an update to that, and going forward we plan to update this report every 3 to 5 years as IBD evolves in Canada and worldwide. And we developed a steering committee and then several working groups to develop independent individual chapters. And the project was largely led by Dr. Ben Shamal, who many of you would know at CHIO, and also by Dr. Gil Kaplan at the University of Calgary, and then by several of us who were a part of the steering committee. And then the working groups comprised well over 20 people dedicated to individual chapters. And there are the different chapters there that comprise this large document, of which I'll go delve into some detail on several of these chapters that I think you'll find very interesting, or I hope. So, you know, an audience's attention is greatest in the first 5 minutes of a talk. So I've decided to start with the conclusions. And so if you listen to nothing else, you'll at least go home remembering some important details about IBD in Canada. So here's one important fact. The number of persons with IBD in Canada in 2018 is estimated to be about 270,000. That's about 0.75% of the Canadian population. And by 2030, forecasting models have suggested that it's going to be as high as 1% of the Canadian population. And when you start hearing 1% of the population, things start becoming a big deal. You know, we start screening for diseases at 2% of the population when they affect things like hepatitis or celiac disease, for example. So 1% of the population resonates with policymakers and payers. And I think that's a number you should remember as going forward. That's what we're probably going to see in about a decade. IBD incidence, which means new diagnoses, in industrialized countries has more or less plateaued, so it hasn't stopped. We're diagnosing, but we're not diagnosing exponentially more patients each year, so it's the same numbers of patients each year, but it is rising in certain risk groups, especially South Asians, so from India, Bangladesh, Nepal, and even extending out to the Middle East. It's always been known to afflict Ashkenazi Jews, Jewish people coming from Central and Western Europe. And in very young children, we're seeing a rise. So children younger than 6 years old in terms of new diagnoses every year. But overall, even though new diagnoses are plateauing, the actual prevalence or the number of people living with the disease is increasing. And that's because IBD patients are living longer. So the number of new diagnoses is not changing, but the length that they carry that disease is increasing. So the actual number of individuals who require care is increasing every year. As we all know, IBD often affects individuals at very critical years of development. So during school years and years of career growth and professional development. And that really, I think, is something that maybe people don't realize, that in terms of, because it's the unknown, what could have been, not what is, right? So that's, I think, something we have to bring to the forefront. Seniors, because of this issue that IBD patients are living longer, seniors are the fastest growing demographic. And they come with their own challenges in terms of managing this disease and all the other comorbidities and drugs that they're on. There's a lot of literature demonstrating that gastroenterologist or specialist care of IBD is important. And individuals tend to have better outcomes if they're managed by specialists both in hospital as well as out of hospital. I don't know why I'm looking there. I have the slides right here. As a silver lining, rates of IBD-related hospitalizations and surgeries have been declining over the past 2 decades, which is nice to see, and that's largely related to improvements in care overall, as we know that the actual number of IBD patients is not decreasing. But IBD persons still have significantly lower health-related quality of life than individuals without IBD. And that affects their development and workplace productivity. The direct costs of caring for IBD, unfortunately, are rising rapidly, and this is dominated by the cost of drugs, the newer drugs that we have available to us, biologic agents predominantly. And then in terms of indirect costs, persons with IBD require more time off work, have reduced workplace productivity as a result of their illness. Persons with IBD often retire prematurely and incur long-term disability. And many patients face out-of-pocket expenses relating to both prescription and over-the-counter and alternative drugs. So those are, I think, the most important take-home messages that came from the larger document, but I think it's interesting to delve a little more deeply into what the literature or data is feeding those statements. So this is work by Gil Kaplan out of Calgary, looking at projecting IBD prevalence into the future. So what they did is they modeled trends in proportion of individuals living with IBD up to roughly 2008 based on the literature that exists to date. And then assuming that there are going to be no major influences impacting IBD diagnoses going forward, projected those trends out in time to come up with the presumed or hypothesized 1% of persons being afflicted with this disease by 2030. And when you look on the right side, do I have a cursor here? No, oh yeah, here. Separated by age groups. So pediatrics, adults, 18 to 64, and then seniors over 65. You can see that IBD prevalence is growing in all 3 demographics, but it's growing the fastest in seniors. And on average, children tend to be more often diagnosed with Crohn's disease, so about a 2-to-1 ratio, whereas seniors tend to be more often diagnosed with ulcerative colitis. So those are some interesting facts that to keep in mind. As far as incidence, which is new diagnoses goes, separated by province, now this only captures about 5 provinces, and Ontario is not part of this list. But that being said, with updated data that we have yet to publish, that includes Ontario, has shown that across Canada, IBD incidence rates are about 18 to 25 per 100,000 persons per year. But in Nova Scotia, it's about double that. And that's been consistently shown. So I don't know if that has something to do with Atlantic salmon or something else, but maybe the Nova Scotians could pipe up and explain what's going on that's different there. There seems to be a consistent trend that, and we presume that that might extrapolate to other eastern provinces as well. We just don't have data from Newfoundland or PEI or New Brunswick. Globally, and most people know this, Canada has amongst the highest rates of IBD in the world, both Crohn's and colitis. And that's true of most developed nations, Scandinavian countries, Oceania, and North America. But what we're actually seeing that's very interesting is a rise in IBD in newly industrialized countries. So countries that have adopted Western lifestyles, and increased manufacturing are starting to see rising rates of IBD. And there are many theories as to why that might be. You've all heard of hygiene hypothesis and various factors looking at exposure to microorganisms in early childhood as potentially being a trigger for development of IBD in the future. But this disease in genetically susceptible individuals does seem to be somehow related to early life exposures. And there are several studies that are ongoing in Canada and have been done, such as the GEM study and now the IMAGINE study, that are hoping to sort out what changes a Western lifestyle has on microbiome in genetically predisposed individuals to help sort out what might be happening early in life that predisposes to this disease later in life. So in Canada, I mean, the rate of newly diagnosed IBD cases is plateauing overall, but rising in Ashkenazi Jews, South Asians, and young children. But as the aging population lives longer, the number of persons living with IBD is going to continue to increase. And interestingly, newly diagnosed IBD cases among second generation South Asians, Middle Easterns, and Africans are just as high as non-immigrants. So the old adage that this is a Western European disease really is not true. And in fact, it is an industrialized country disease. And for and even more interestingly, when immigrants move to an industrialized nation such as Canada, they adopt risk of developing IBD. So for every decade earlier in life that they move to Canada, they have a 10% higher risk of developing IBD. So these are very interesting associations. Why this is happening, nobody really knows yet, but these are the underpinnings for a lot of the research work that's going on right now. Interestingly, East Asians, so largely predominantly China and Hong Kong, have amongst the lowest rates of IBD, even amongst second generations. So there must be some protective genetics in that population of individuals. And I don't see any East Asians here in the crowd, so I'm not lying. Just flipping to outcomes amongst IBD patients. This is slightly historical data published recently, but based on data pre-2015 perhaps, that shows that the risk of an intestinal resection, either a small bowel resection or colectomy amongst Crohn's or colitis patients, tends to be more prevalent early in the course of disease amongst individuals diagnosed at an older age. So children tend to have a lower rates of surgery early on, but by 10 years, the rates of surgery are pretty much the same across the board. And for Crohn's disease, it tends to be around roughly 30% by 10 years. That's mostly intestinal resections. And then for ulcerative colitis, roughly 15% by about 10 years. If you look at all of these, and these are bar graphs based on age of diagnosis. So less than 6, and then 6 to 10, et cetera, going all the way out to elderly. Fortunately, based on Ontario data, we are seeing declining trends in hospitalizations and surgeries, and that's fortunate. So even going back as far as the early 90s, but continuing out to 2012, we're seeing persistently declining trends in hospitalization and surgery rates. And we know that incidence of IBD is not decreasing, the prevalence is increasing, so this relates to improved care. So that's, I think, a nice silver lining that we can be proud of. You know, we talked about specialist care being important. So, you know, what we have seen is that early gastroenterologist IBD care is associated with reduced risks of surgeries and emergency department visits. So I think it's very important for newly diagnosed IBD patients to be hooked up with somebody who understands this disease well. And I think it's probably most important in the early years of disease when a lot of disease damage can occur and to halt that before that happens. We're still not doing very well on getting to IBD diagnosis quickly. So the average time nationally is still over 6 months from symptom onset to disease diagnosis. That's probably a lot lower than many of you waited. But in the current era of the technology that we have, it probably should be faster than that. But fortunately, more and more people are seeing a gastroenterologist within the first year, so upwards of 88% in some provinces. But only about a third are getting ongoing gastroenterologist care going forward. right? And so, some of that, of course, is individuals with milder disease who may not always need to see a gastroenterologist, but some of those patients obviously have poorer access, and we need to fix that. And seniors and rural residents have been identified as two sort of marginalized population that seem to see a gastroenterologist less. We presume part of it is poorer access, and then that's the part we really need to tackle and address. Country. So that was sort of IBD epidemiology, which talks about incidence prevalence. I want to switch gears a little bit to costs, okay? Because as IBD prevalence increases and our use of drugs increase, costs are increasing a lot. And they, people are there's probably many people in this room who've been frustrated with the time it took for them to get on appropriate drugs. And that's completely understandable and justifiable, but putting it in perspective might help you understand why this is becoming a growing challenge for payers and for the healthcare system in general. So this is data from 2012 on the left. That's the first impact report. And what they showed then was that of all healthcare expenditures, more than roughly 40% are due to drugs, okay? And then roughly a third due to hospitalizations. So in 2012, over $500 million a year was being spent on IBD-related drugs. In 2018, we've estimated that the direct costs of care, so relating to costs that the healthcare system pays for, not talking about indirect costs such as lost productivity, but pure money paid is about $1.3 billion across Canada, of which 42% is spent on prescription drugs. And 7 of the top 10 selling drugs in Canada, we're talking about chemotherapy, antibiotics, PPIs, prescription drugs. 7 of the top 10 are biologic agents, right? Obviously, 7 out of 10 individuals are not walking around with immune-mediated diseases, right? So we're seeing a major utilization of these drug classes. And in fact, it's much more so in Canada than it is in other industrialized countries. As a market share, the amount we spend on biologics as a percentage is higher than the US, than Europe, than anywhere else. So we like our biologics here. Anti-TNF agents, Remicade, Humira, Simponi, alone account for 8.7% of the pharmaceutical market share as a single class of drug, right? So you can imagine if you're a payer or policymaker who's faced with cancer, cardiovascular disease, diabetes, and one of another 1,000 disease states, and you learn that close to 10% of your drugs of your pharmaceutical budget is being spent on one class of drugs targeting immune-mediated diseases. These are challenges that we face, and unfortunately, and really, the rising drug costs are not going to be offset by reduced healthcare services utilization, and that probably can never happen because the costs of health services such as hospitalization and surgeries tend to be one-time or two-time costs and much lower than the annual cost of receiving a continued biologic therapy. And in Manitoba, they looked at what are the costliest scenarios in IBD, and they found that the first year of diagnosis was a costly period, roughly $6,600 per person in that year. Individuals who needed to be hospitalized cost the healthcare system roughly $13,000 in that year. Individuals who needed a major abdominal surgery cost the healthcare system roughly $18,000 to $19,000 that year. But individuals needing anti-TNF therapy cost the healthcare system $31,000 in a given year. Okay, these patients are presumably feeling better, and so that is the plus here. But it is not without, that does not come without costs. Updated data from Manitoba, very interestingly, showing that in the year, among taking all IBD patients in the year prior to receiving an anti-TNF agent, so these are just users, individuals who received Remicade or Humira, the year prior to receiving the drug, their healthcare cost was roughly $10,000, and in the year following receipt of the drug, the cost was about $46,000. So the costs are going up 4 to 5 times, and those costs are continuous because the vast majority of that cost is the drug itself, which at this present time we don't stop. And the cost amongst people who continue to use the drug goes up with time. So these bars are reflecting the first, second, third, fourth, and fifth year of therapy. So these are individuals with Crohn's who, reflecting all people who started a drug, but these are individuals who continued the drug through 5 years. And you can see that the costs increase, and that's because we tend to dose intensify to achieve optimal control. And the same thing for ulcerative colitis, and in fact, ulcerative colitis tends to be a bit more expensive as far as biologic costs goes. We've found that the drug, that condition doesn't respond quite as well and often requires higher doses of drug. And in Ontario, in terms of public payer drug costs, right, we're kind of seeing somewhat comparable trends, but what's interesting is that as a whole, so this is Crohn's on the left, ulcerative colitis on the right, and the top two graphs represent all persons with IBD. So these are average public payer drug costs average across all IBD patients. And we are definitely seeing a rise in Crohn's disease, right? And what we're seeing is that what we looked at was the trends prior to the introduction of the first biologic agent, which was Remicade, which happened right here, and then the trends following its introduction, okay? And what we plotted was the expected trends in the absence of drug introduction, which is really a continuation of what was happening before the drug was introduced to the marketplace, and then the trends after its introduction, which is the scooped line. I can't get this pointer over from me, right there. Okay, so we're seeing a rise in drug costs in Crohn's. Surprisingly, we're not seeing that rise in drug costs in ulcerative colitis, which is on the right. And you can see here that the observed trends following marketplace anti-TNF introduction are superimposed on the expected trends. However, when we look at anti-TNF users specifically, so these are now individuals who received drug at some point in their disease course, we can actually see that in ulcerative colitis there is an increase in cost. So really what we're seeing is that the drug is not being used as much in ulcerative colitis. So on average, it doesn't seem to be making a spike in cost. But in Crohn's, certainly we are using the drug much more. And what we've identified is we're using the drug roughly 30 to 40% of Crohn's patients and about 10% of ulcerative colitis patients right now. And what is perhaps a little dejecting is that although we all know that these drugs work well, they've been demonstrated in randomized controlled trials to work, and we all have patients who've achieved excellent disease control for years, but at a population level, despite the increasing costs of these agents, so driving up healthcare expenditures dramatically, we haven't made a dent in hospitalization or surgery rates since their introduction. And this is data from Ontario, where, again, we looked at trends pre-introduction, marketplace introduction of anti-TNF therapy, and trends post. This is all patients, okay, looking at hospitalizations here on the left, IBD surgeries, which are intestinal resections on the right, Crohn's disease, ulcerative colitis, all patients, trends post are overlapping with trends pre. Okay, what's perhaps more concerning is in Crohn's disease, even amongst anti-TNF users, people who got the drug at some point in their disease course, there's absolutely no decline over expected trends in hospitalization or surgery rates. We do incidentally see a decline in hospitalization rates amongst UC anti-TNF users, which is fortuitous, but unfortunately it's being washed out by our low usage of anti-TNF in the UC population. But the Crohn's data are concerning and speak to the challenge of actually achieving maximal benefit from these agents. And what this tells us really is that at a population level, these drugs are not always being used right. So we know they work, we've seen patients that they work in, and we know from randomized data they work, but at a population level, we're not seeing some important benefits that we should be seeing. This, of course, doesn't look at health-related quality of life. It doesn't look at workplace productivity. It doesn't capture a lot of things, which are also important, of course. But these are two important things that we should be modifying with drugs at this cost level that are touted as disease-modifying drugs. So something to keep in mind from a public policy and payer perspective when you're wondering about why it's so hard to get access and things like this. These are some of the challenges that we're facing in terms of rising costs and not potentially getting the bang for our buck that we need to get. So cost implications of biologic therapies. So following initiation, healthcare costs increased by 5 to 10-fold for users of biologic therapies. The average healthcare cost per biologic user is about $40,000 to $50,000 per year, indefinitely. It's forever. as far as as our current literature tells us, because what has been reliably shown is that individuals who stop this therapy, even in the best of health, about 50% flare within the first year and about 80 to 90% flare by 2 years. So right now we don't have an out from using these treatments. And on average, costs tend to increase over time with dose escalation. And so right now, we estimate about a third of individuals living with IBD are on biologic therapies. So if you take that 270,000 Canadians living with IBD, a third of those patients times 40,000 per year, we're talking about more than $3 billion per year spent on biologics alone for IBD across Canada. To put that into context, the cost of a major abdominal surgery one time is about 15 to 30,000 once. Right, and so these are sort of competing things when you come to a cost issue that sort of, often play into decision making at a policy level, sometimes also at a healthcare provider level. Okay, so that was direct costs. Hope didn't throw everyone's mood in the gutter there, but we're still going to be using these drugs. They're going to be there. Just we have to find very smart ways to use them and to continue getting access for them. Indirect healthcare costs. This is a forgotten area of the whole picture. And it's hard to quantify, right? And so this is the story of what could have been as opposed to what is. And what this reflects is the portion of human capital that is foregone due to illness and disability, as well as out-of-pocket costs that aren't registered in the healthcare system, the total budget. So they really break it down into two types of costs. One is absenteeism, where individuals are not at work, and that can be very easily boiled down to a dollar value based on earnings per day. And then presenteeism, which is much harder to actually quantify, which relates to reduced workplace productivity. So even though you're at work, maybe you're working at half capacity. And from a societal perspective, there is a cost associated with that. And so these are often not considered in cost of illness calculations. And they're also not considered when we talk about justification for the cost of biologic agents. So people are all looking at the measurable, clear-cut costs like hospitalizations and surgeries, but there is a whole amount of cost that's buried that we need to access. And this was identified as a major priority area for research going forward, trying to harness what is actually happening beyond just hospitalizations and surgeries that are making IBD treatment a cost-effective strategy. So similar to direct costs, total indirect costs based on available data, we estimated at 1.3 billion. But you remember that the only data we have really are absenteeism data. We don't have presenteeism data. So this doesn't consider the cost of reduced workplace productivity, the cost of lost professional development, and even caregiver costs, which are probably a substantial component of this illness. So the actual indirect cost of illness may be much higher than 1.3 billion, potentially double that. The average lifetime lost wages due to premature retirement is over $1 million per person. So what that means is that in any given year, if you took if you looked at retirement across the IBD population and estimated that the expected age of retirement is 65, and you took all the years less than 65 that people retired and averaged it across everybody with IBD, so many of whom would have worked to 65 or beyond, even then the average loss is about $1 million per person in lifetime earnings. So that's a big deal. And this is based on average wages. We're not talking about luxury wages. These are average wages. Workplace attendance and productivity are factors that really need to be part of the equation. So 33 million in permanent lost wages due to premature death. And we don't have a good figure for costs of complementary and alternative medicines, but we do know that upwards of 3/4 of IBD patients are spending money out of pocket looking for other solutions for their disease. And this is one study from a US referral center where they looked at the rates of absenteeism, presenteeism, and then put a dollar value to it in terms of weekly earnings. And you can see here on the left that individuals who had active IBD, close to half of them rated reduced workplace attendance, and almost 100% of them rated reduced workplace productivity. Even IBD patients in remission, more than half of individuals rated reduced workplace productivity as compared to individuals without IBD, so about double, okay? Even in remission. So there's obviously factors beyond just having bowel movements that are going into efficiency. And then when you look at lost wages as a result of these factors, active IBD patients were estimated to be losing about 20% of their earnings due to not showing up to work because of their illness, and up to 30% or more because of reduced workplace productivity, and overall more than 50% of weekly wages lost due to illness and factors associated with illness. So these are important parameters that we need to keep in mind. So societal costs relating to IBD amount to at least $3 billion, both in direct and indirect costs, but it's probably likely much higher than that, probably closer to $5 billion if we were able to calculate everything. And direct costs will continue to rise with rising prevalence and rising use of biologic therapies. So we need studies to address the impact of biologic therapies on indirect costs. I think that's going to be very important. We also need educational and policy initiatives to maximize the value derived for the money spent on these agents in direct, in terms of direct costs. And we need strategies overall to offer good and better care at a lower cost in order to compete in the ever-growing competitive marketplace of illness. So I'm going to skip over children because you have an expert on children talking to you next, and I'm far from that. So I'll wait to be educated about that myself. But we'll talk a bit about seniors because this is a growing demographic that we need to be aware of. They present challenges in terms of managing other comorbidities and managing other medications that they're on, so-called polypharmacy. So we talked about how they're the fastest growing demographic due to ongoing diagnoses, but patients living longer. 15% of IBD patients are newly diagnosed after age 65, so a minority, but most IBD patients make it past 65. So this is important to remember. And they're more commonly diagnosed with ulcerative colitis than Crohn's in the over 65 group. Fortunately, they tend to follow a milder disease course than younger onset IBD, so often they will have disease isolated to the colon if they're Crohn's without penetrating complications or strictures. With ulcerative colitis, they often have limited extent and severity of disease, but yet they have higher rates of surgery and surgery-related morbidity. And that may reflect a collective decision to avoid exposure to immunosuppressants long-term amongst the elderly, despite having less severe disease. And of course, treatment, as mentioned, can be more challenging due to perceived or real infection risk, comorbidities, and polypharmacy. And on the whole, we see that playing out in people's actions, in that biologics are used less frequently in the elderly population. Part of that could be milder disease, but part of it is also reticence on the part of patients and clinicians. And it's been established that there's definitely higher risk of lymphoma with thiopurines in the elderly population than there are with younger. So anybody here who's older, in the older demographic who's been on azathioprine or 6-MP for decades, please talk to your doctor about that. So we've sort of covered this, that the incidence here amongst, for the most part, had plateaued. There seems to be a late surge amongst adults and children, but elderly who are in the red are flatline for the most part. That's new diagnoses. But if you look at people living with disease, the red line is actually increasing faster than any other demographic. So incidence of IBD-related surgeries, we see here in Crohn's elderly, the cumulative rate over time, the curve is about similar to young adults, but ulcerative colitis, they seem to have a much higher rate of colectomy. And that despite having generally milder disease, that can only speak to collective decision-making as opposed to the most appropriate strategy of care. So in summary, Canada has amongst the highest rates of IBD in the world. The prevalence is rising, expected to rise to about 1% by 2030. Elderly IBD patients are the fastest growing group and face unique challenges. Very young children, as you'll hear about, are the fastest growing group of new IBD diagnoses. Seniors and rural residents are less likely to receive gastroenterologist care. Hospitalization and surgery rates are declining, fortunately, due to improvements in care, but the costs of IBD remain substantial and are rapidly rising due to biologic therapies and are going to be a major consideration going forward. And indirect costs are substantial and under-recognized, and we need to do a better job of capturing that as well. So don't forget about the Gutsy walk, and I'm happy to take questions at the end, I believe.